Okay, so welcome everyone to Digital Dispatches, and today we're joined by Raied, who's the Programme Manager for Encompass, and we always get a good turnout for Encompass, and having gone live in South Eastern Trust back in November and planning for go live in Belfast Trust in June. Raied has come along today to talk us through some of the lessons learned, some of the discussions that have been going on as to what worked well, and perhaps things that maybe they will change for the go live in Belfast. So without further ado, Raied, I'll pass over to yourself to kick us off today.
Thank you very much, Dawn, and welcome everybody. Lessons learned is the title, and I believe we've got 5 hours for it today, so that's good. We can cover the key topics. I'm Raied Abdul-Karim. I'm the Encompass Program Director. A little bit about my background. I worked in the National Health Service for over 20 years, and as a Program Director or CIO or Director of Corporate Services, and worked internationally as Director of Programs for the energy sector. My doctorate is not medical, it's Cranfield Management, and my base foundation training is as electronic engineering, which I hold a degree and a master degree in. Change management is a big aspect for me, and I'm internationally certified change leader as well. So that's, I think for me, this is an interesting topic we're talking about all the time at the moment, but I will try to structure the conversation as much as possible. I want it to be as informal as possible and to allow you to ask questions and we interact on maybe key topics that might be important to you as well. So for the sake of, I guess, structuring the conversation, I will talk maybe the key pillars of the program, and the Encompass program, the way I would define its pillars. One is about the program itself and its governance. One is around the technical pillar of the program, and I will tell you a little bit what that entails. Then business change and training as the third pillar. The fourth pillar is the build and testing of the system. And the fifth pillar is the post-life and what that looks like and what we're doing. So these are kind of the key pillars that I will talk about. So I will kick off with what we'll do. Let me run through maybe my quick talk on these, and then we will open up for questions and answer and a discussion on some of these topics. It's a complex, very wide-ranging program. I may not be able to answer all the questions, but we are doing a lot of work in this space if you are interested in lessons learned. One of the key things we are planning is end of February, beginning of March, we will have more likely to have a full day on lessons learned, and bringing in some of the Southeast and maybe others and opening it to everybody across Northern Ireland to come and join the event. But we are also collating some of these lessons learned in a formal document that will be open and shared with everybody who would like to access to it. So on the governance and setup of the program, I think the key things for the program to succeed is making sure we position it as we have done, as a clinically led program, digitally enabled. And that's very important because it's about how we deliver services to our patients, how our professional colleagues use the tools to deliver services. So it is driven by clinical colleagues, but technology is a big part of it, and we need to make sure the technology as a tool is available, is enabler rather than an obstacle to the way we deliver our program and our work. So that's the key ethos of the program, if you like. The governance structure we had, it is probably unique in the world, I would say, the Encompass and how is it managed. I came from, prior to this, I was at Royal Devon, where I've implemented the same digital system, which is Epic at the heart of it, in Royal Devon and Exeter, and then I've implemented the same at North Devon. And why is this different? Because this is a countrywide. It's a program of number of trust and different go lives. And the complexity comes from We have gone live on the 9th of November successfully on time with Southeastern. And normally trust will move into a stabilization phase and the resources will be focused on helping that trust to stabilize and go and embed everything into business as usual. While here, where we have to work with stabilizing the Southeastern, while at the same time working with the biggest trust, one of the biggest trusts in the UK and the biggest trust in Northern Ireland, Belfast, getting them ready for go live in a few months' time. And that makes it very challenging. While at the same time working with Northern, Western, and Southern, making sure some of the early activities are ready, otherwise we will not hit their go live dates. So that's part of the complexity of a program in terms of the program and governance. Secondly, that means changes are cannot be as sometimes as agile as we would like them, because if we want to make change, we need to make sure we get in support regionally to that. So not one trust can suggest something and then we go ahead with it. We need to have input from the other trust to make sure it's fit for purpose, and because it's a central system. So there are large number of regional governance groups that have been sprung up over the past 2 years or so, looking at the build, looking at the scope, looking at the changes with various representation. And to have so many groups managing them, just the logistic and administrative becomes very complex. But it helped us to get people connected and stayed connected with the program and have the level of ownership required. It's not without its faults, because sometimes you don't get the right representation from the trust, or representative are not taking it seriously, and sometimes the louder voice maybe influence the direction of travel. We try to mitigate some of this as much as possible with how we managing things. As part of the governance, I'll talk about comms. Comms, as you know, with every program is a key enabler. And for our first go live, the trust has done a significantly good job at Southeastern and led the communication from social media to internal comms, working with our central team, with Paul and others. And I think it is an outstanding piece in terms of engaging the public, engaging the patient, engaging the staff. Risk and management, again, the management of that is quite complex, but I think we've done a reasonable job in managing risk and having visibility on that. And I will talk about the actual go live event and how we manage that. With every Epic implementation, we go through a very systematic approach for assessing risk, and it is called go live readiness assessment. And we've done it at 150 days before go live, 120, 90, 60, 30, 15 days. Each of these days, we will have attendees between 100 to 300 people coming from operationally from the program to evaluate, understand the risks, and discuss mitigations. So I think that puts us in a good place in terms of openness and transparency about risk, joint ownership between the program as well as the operational colleagues of how we manage risk, how we discuss challenges. It's very important, the issue of ownership, because if the trust or the organization see it as a central program and people out there deal with it, they will soon run into trouble, because it's a tool that impacts everybody in the organization. And if you think about when I say everybody, the porters will have got new ways of working. They've got new devices. They've got new workflows. The domestic services, they have new ways of working. Admin services, secretaries, allied health professions, the nurses workforce, the midwifery, the doctors, the consultant, the juniors, the students, the agency staff that come in, all of them will be impacted. The managers, the reporting. That's why it is a transformation program, because it changes the ways of working rather than just talking about the technology element of it. And that brings the level of ownership becomes very important, because you need to embed that change, because people can drift and go back to the status quo. I'll stop talking about the governance element and the program and move to some of the lessons on technical. The technical, again, is loads of elements into it. A typical program, you will have data migration, which is a key challenge. And I think we've done a reasonable job in this, but the key lessons for us probably from data migration is to agree and sign off the scope for data migration. Which systems, which data need to be migrated? How long? What is the period it covers? And then more importantly, the validation of that data. Validation of that data requires professional people who understand that data to validate that data and say, yeah, what is in the system coming over, it is fit and right. And we have one or two instances, if you like, breaches post-life, and the result of it was some elements missed on data quality and checks. So data quality is very important and defining the scope for data migration. Sorry, you have to excuse me, my voice. I just came from program board presentation for the last an hour and a half. So technical, we said data migration, and then you've got third-party systems. My last implementation, I've counted the system I had, I think it was about 150 different systems that we need to have a clear status about that will migrate or interface to Encompass. So if you think about that complexity, relying and talking to third-party systems, suppliers, having procurement of test systems. Some of them might not want to interact with you because you're moving away from their system into a different system, moving from a third party to Encompass. So they don't have vested interest in really talking to you or engaging with you. So building that relationship, how you make sure you get the right input, you have the right time for some of these discussions for third party systems. But it becomes very important dependencies, because without some of these interfaces, the system Encompass will not go live safely. So third party is a big area. The earlier you start on them, on the analysis, the better. All the logistic around understanding each contract, the timeline, the licenses, the impact clause within these contracts of terminations is a big headache and a big logistic nightmare. Help desk arrangement, some of it technical, some of it more than technical, agreeing that having the resources for it, agreeing the process, agreeing the prioritization. I think fair to say for Southeastern, we've done a reasonable job, but we started late on some of these areas. And probably to date, we don't have a robust out of hours coverage for support. We're relying on staff goodwill to provide out of hours. And we are working currently to put some proper arrangement for coverage for out of hours. It is a new concept for a lot of people in Northern Ireland. Now we have a major system in place. The system becomes part and parcel of service delivery. So if there's a fault or problem with it, the professional cannot deliver the services they need. So having the support around them becomes very vital. The other technical element is end user devices, referred to EUD. There are thousands of new devices gets procured, set up, implemented, and tested in order for Encompass to work correctly. And it is a very, very complex process because of the various stages of this. Just having the funding, then going through a procurement or delays internationally in the market for certain devices can delay you and can hinder your progress. But more importantly is really getting the end users, which is the trust, to identify what are their requirements. With the Encompass comes portfolio of devices, from handheld devices we refer to as rovers, which effectively telephone, to different devices such as the Chromebook, mobile computer on wheel in different connotations, as well as laptop and the traditional desktops. Different types of printers, mobile printers, Wi-Fi, all of them makes EUD is a very complex project. And defining what is required and what's the portfolio of devices in each working area becomes as well as a cumbersome. And validating this, do they map to the funding available? Some workflows don't work on handheld devices, some will work on mobile devices. You've got workforce and community and social work, which are mobile people. Have we catered for them when they go out to have the right signal to connect to the system? Did we look where there is no signal, for example? This is one key thing. move to an area where there's limited signal for Wi-Fi, and you might rely on patients' home internet to access the system and get that connectivity. And then what is the policy and governance around some of these issues? So technical moves into a number of areas and becomes quite a cumbersome area. And not to mention, we are working with health and social care organizations. So medical devices on top of that are vitals. So medical devices will send and receive information from the system, all vital information. So making sure the interface between medical devices and the system tested and the information flow is very important and could have significant impact on patient safety. It's very detailed pieces of work with specialist suppliers to get that work done. I'll park. There are loads to talk about in terms of the technical element, but I will park it just giving you a flavor of this area. And then the build of the system and testing of the system. We mentioned regional governance group who validated some of the workflows, but at the end of the day, the system have to be built. Test scripts and the probably over 100 test scripts have to be developed. End-to-end patient journey have to be tested on the system. And more importantly, getting people from the trusts to test the system and test these scripts to see, does the patient workflow make sense? Does that flow and movement of information make sense? And making these judgment and scoring and passing or otherwise the test scripts. And the other probably key risk that and key learning, the impact on operational staff is significant before go live, because they have to support testing, they have to support some of the build, they have to support one key area, which we call manual data migration, where you cut over from one system to encompass, moving a lot of these data manually, which means you require professionals who understand the data and can validate the data. This could be prescribing data where you need pharmacy technicians, or it could be some critical clinical data, especially for patients that are already in and going to be in post-life. So the manual data migration and the impact on operational staff being pulled out from their daily routine to support the program is a significant learning. We were late in identifying those people, the size of the ask. We're getting better in terms of doing some of that work with Belfast, where at least they've got visibility of how many people, how many hours, what is the effort required. I'll go to business change and training. As we've said, this is a major transformational change program. And as a result, large thousands of people get impacted by it. A lot of people feel uncomfortable with the change, and generally people are creature of habits. They're happy with the safe environment they're working with, the knowledge they've gained. To some people, you are telling them all the knowledge you've gained in using the tools is going to disappear, and you have to learn something new to do your work. And that is quite challenging really for people and quite daunting. We need to bear that in mind. The what's in it for me element is very important. The support element at the back of that change becomes very crucial, and you need to take the staff with you. EPIC is #1 in the world and has been for probably the past 10 years. If you look at independent assessment from organizations such as CLAS of EHR assessment, will put EPIC at the top. But it doesn't matter where it is. If you don't take the staff with you through the change journey, the system can sit and gather dust and will not be used and utilized properly. So the change becomes a fundamental element to the success and to the benefit realization, and eventually to optimization and thriving in the use of the system. We do have in the program dedicated resources. We try to follow a structured methodology. I've introduced the concept, if some of you are familiar with the change management model of ProSci. They use a model called ADKAR, which is about the awareness, desire, and then the knowledge, ability, and sustainability. But it is an important element and we cannot overlook. And then the training. The training is probably an absolute nightmare. It's getting 9,000, 10,000 staff trained within few weeks. if you think about the logistic of it, the number of rooms, the tools you need, the computers, the paperwork, the booking system, the mapping of each person within the trust to the right training tracks. There are many, many training tracks, and making sure that mapping is correct so staff can receive the appropriate training was very, very complex. Some of it is due to the fact our HRPTS system is not up to date and not accurate. And as a result, when you use the system to map, you come up with number of anomalies. Or actually although this person have this title, they do totally different activities and they need to attend a different training track. And then managing affiliate staff. So you've got students that will come in, you will have agency staff, you've got locum, and you need to manage those. Those are not directly controlled by the trust or by us, but we need to have the relationship with the agency. We have done a reasonable job to manage those groups, but certainly we can improve on these areas by identifying the numbers, the agencies. We're trying to engage with the agencies and banks earlier on to make sure those staff have access to training and materials. So when they come in, at least they have the basic knowledge. So training is a key enabler. You will see it as a theme throughout to go live and one of the big risks. And then post-life in terms of people feeling, do they have the skills or not, the quality of the training. The final thing I will talk about before opening up for discussions is the post-life. I guess the post-life is certainly for me, the areas that are emerged are not big surprises. But as we've went through a structured approach for the go live, we're going through a structured approach for post-live. We do 3 structured visits called post-live visits to the trust, where our tens of people from EPIC and Encompass go and shadow operational people doing their jobs to see how are they doing, what are their concerns, what is their feeling about the system, what areas of improvements they would require. And that gets captured formally every 2 months for the next 6 months. So we can see what is the adoption level and what are the improvements required. The key areas that have emerged from our first post-life assessment: administration staff, administrative staff. They are key pillars for the delivery of clinical services. And we probably didn't pay enough attention to some of the workflows and the engagement of that staff group. And so now we have set up a task and finish group to deal with all the admin areas and see we can make them as stable as possible. Reporting is a key element because it exposes the organization to the center, to the wider world. If they haven't got the data correct, if they haven't been able to pull the data, if they're not been able to report on service delivery plan or regulatory reporting. So it's another focus area. We are struggling in that area and trying to improve on, again, formulating a task and finish group for this area. Maternity is a complex area, is more or less is a hospital of its own because of its complexity and the way they work and quite different. And pharmacy with its complications for the medication dispensing, medication ordering, the inventory, robots, interface makes it quite cumbersome. Images as a whole, radiology and others, and archiving, retrieving and access of images, where some of it sits at the boundaries with other major programs such as the NIPIMS, NIPACs, it becomes very important. And then the lab, which we're relying on NIPIMS and the interface between that system and Encompass, added another complexity in terms of aligning other dependent program activities and readiness with Encompass to go live safely. So just as this is a flavor of, I guess, just trying to take you through some of the key things in the program. I mean, this is just touching the iceberg of the complexity we're working with. But I want to use maybe the next 15 minutes or so for questions, clarifications, things maybe I haven't covered or missed. Feel free, please.
We've got 2 questions in the chat, Raied, if we wanted to look at those before anyone else puts their hand up. They're sort of really focusing on in what's been happening in Southeastern Trust. So our senior user managers happy with the benefits that Encompass is providing? I think it's very early days for that, but
yeah, I think it's a really good question. Benefit is part of my doctorate was on IT-enabled change benefit realization at Cranfield. It is a very complex area, and it's complex because at the go-live period, everybody's focused on getting the go-live out of the way. At the post-go-live period, people just want to stabilize and deal with the issues that are emerging. And as a result, some of it falls down because of distraction of where you are in that. However, we have categorized the benefits into different buckets. And the first one is kind of a quick cash releasing benefits. And this relates to switching off some of the IT system, for example, that we no longer need. And we realize the resources from that, whether it will be contract or the repositioning of the staff who used to support that system. There is another category of time releasing benefits, which will come once we improve the personalization of the system. And this is staff can do things quicker. They can do things more efficiently. They can see the full picture between health, social care, mental health. They have the full picture of the patient. They can make more informed decision. And there is more qualitative benefits. All of these with numbers have been categorized. I think we need, there are assumptions made as well at the business case in terms of what benefits we realize. They're usually not 100% when you do it at the business case. And some of the work we're doing now is trying to baseline some of these benefits in reality to see, are they still stick? Have we got the right quantification for them? And more importantly, have we got the right ownership, operational ownership for these benefits? So it's a work track that we are managing and working with, and we've got a number of things that have been done on this area, but more can be done. Training, just to go at training, I think is a comment. Will there be training manuals, video to assist refreshers training? There are probably hundreds of videos already in place and available. There are tip sheets on a number of things which can be shared across organizations. All of these materials are available and shareable, and people can use them ahead of time just to familiarize themselves. The learning comes from different folds. We're doing, for example, specialist training, where colleagues who can receive super users get trained ahead of time, and they can train their colleague. We've got the playground, which is effectively a sandpit where people can go and play with the system and get more familiar with what the system looks like. And we try to set up end user devices labs where people can get familiar, touch and feel some of the new devices and how they interact with the system. So I think a question about impact on appointment scene. I don't know the overall impact, but I will give you in terms of planning. Each go live that has been, certainly in the UK, and I've attended the University College London, Great Ormond Street, and then the next two where I've managed. There goes to a structured plan to reduce the level of activities that the trust undertake during go live. So we know that is a given. The level of activities, whether it's especially around elective, they get reduced, and that reduction gets agreed out operationally by the different department, then the trust sign it off, then the encompass regionally sign it off. And we have done the same with Southeastern, where we've agreed number of weeks reduction in number of areas, and we're just tracking now to see when are we going back up to full capacity. So reduction is there, is agreed prior to go live, and we're just monitoring when we're going to go back to full capacity. After implementation, so we've got trainers. We have permanent trainers. So just to give you flavor, since Southeastern gone live, over 1,600 staff being trained post go live, with over 400 training sessions being delivered and 18 virtual sessions being delivered. So training will continue, and we have people who will deliver training for an ongoing basis. some of it to existing staff who are struggling, some of it to newcomers, some of it to agency and affiliate staff.
Just one there, Raied. Did you say that there's a task and finish group being set up regarding pooling data? Does this relate to data quality and migration issues?
So the data quality touches everywhere. A big element of it in the admin and a big element of it in analytic and reporting. And both of these, they are included in the task and finish group, particularly around some of the work groups, work tasks, work queues, where we need to make sure we get the right ownership and they are managed correctly. So data quality is an element of, it's going to be an element of each task and finish group, but predominantly the admin, the reporting and analytic is part of that.
That's all the questions at the minute that are in the chat. If we want to open the floor up.
Anybody want to speak out? Don't shy away.
There's just one more has gone in. How many man hours were required for manual data migration by clinical staff? And did this have any impact on patient care?
Yeah, I don't have the numbers top of my head, but I went through it Devin went through it for Southeastern, probably thousands of hours. But they divided, the way we've done it is, it just goes through each area, each professional group. So it is medical secretaries, for example, midwiferys. And we say this is the number of hours required from that professional group over what period are required. So we've got that data available, but it is loads of hours. What I've seen evidence of seeing go live, stabilized and moved on, the more you invest in your data upfront, the more you're engaged, the better stabilization you will get post-live and the easier transition you will make from a go live to a business as usual. So it's an investment worthwhile. As they say, there's no pain, no gain. And I think it is painful, especially when we know health and social care services are stretched and there's loads of demands and we are just still in the winter pressure period. So asking people to do that is very tricky, and getting that balance is probably one of the top challenges for the program. But it pays dividends from what we've seen.
Anyone open to the floor? Anyone else have any questions or they want to come on? Simon Higgs, you have your hands raised.
Hi there. Yes, I'm Simon Higgs. I'm Southeastern Trust, and I'm in the pain service, the chronic pain department. We are still in a situation where over 3 months later, we are still not able to increase our clinics back up from what they were like at go live due to build issues. So I just wanted to see what are the plans in place for looking at outlying areas such as outpatients and day case, where the build has not been correctly completed, and where workflows, work lists, and waiting lists are all a complete mess at the moment.
So that's our top priority is around some of the workflows, work list, work queues. The task and finish group is being set up, and they've been working on in task and finish group mode for a while, but now we formalized it with a work plan. What we have done, I think this is be recognized as in terms of how we manage, certainly for my challenges, how I manage the resources to make sure Southeastern is stable while I'm getting enough attention to getting Belfast ready. And it's a massive challenge for staff really to split that. But we've agreed now a dedicated lead for stabilization for Southeastern. Furthermore, we've identified an encompass lead for each area that requires attention, an epic lead for each area that requires attention. And we've asked the trust to identify the right lead for these areas to make sure there's a single point of contact to make progress on these areas. We have managed to get the Southeastern now to transition from a go live mode to operational mode. where we've set up, and this week we had the first meeting of the oversight group, which is, we've called it the CDOG, which is the Clinical Digital Operational Oversight Groups. And all the task and finish groups, progress and accountability, will go to that group, which meets weekly to make that progress. So we acknowledge the gaps in some of these areas, but we are taking active actions. I wouldn't say proactive because we're trying to manage a number of things, but clear active actions that we've agreed with the senior leadership at Southeastern, with Helen, with Roshin, with David. And that, as I say, that structure now has started this week. So Simon, that might not answer you full, but at least it gives you some confidence. It is on our radar and we are taking some serious actions around it.
Okay, thank you.
Is there a particular DDVR system that is being used with Encompass?
So the digital dictation system, we look at it as a key enabler and support tool for Encompass and all EPR, EHR. Probably, I'm not mistakenly, if I make that statement, every trust that gone live with Epic system, they had the digital dictation system available prior to go live. And that has helped and reduced the impact, particularly on clinical colleagues. We currently don't have it in here. There's a business case for it, but funding has not been identified for it, particularly the revenue element. It's been escalated to the highest level, and permanent secretary is aware of it. He attends the program board, and we made the case to him. He's very sympathetic, and they're trying to find funding for support in this. It will be a very useful and an enabling tool for the rest of the trust if we go live with it earlier. So that's the position on DDVR. And there are a number of systems available. Model and Dragon are the two key systems that can deliver these services and being used elsewhere.
Thank you. Anyone else for any more questions?
Going once. Feel free to filter questions through Paul and colleagues, and we will do our best to respond in a timed manner as much as possible.
Yes. Don't forget, guys, there's Encompass teams, for each of the trusts. If you have anything, specific to what's going on at the minute in your respective trust, you can find the contact details for that in the Encompass newsletter.
Yeah, and I guess my final thought is, if you have opportunity to get engaged as early as possible with the program, this is the systems, the tool, the program that will be around for at least the next 2 decades. These are the EPR. They're not something that you will bring in for a year and move on from. The life cycle of the, I think, business case is about 13 years. So it will help you to get familiar with the system. It's for, even if you look at it selfishly, will probably give you the skills, the knowledge ahead of time, and you will have an easier journey transitioning in your job to making sure you can do your job more effectively. So my advice is try to engage as early as possible and don't look at it as an add-on, because soon it will be embedded and you will not be able to do your work without it.
Thank you very much, Raied. That was really good. I don't think we have any more questions coming through. I think that's us. Paul has put some links in the chat there, one to the DHC&I website, the Encompass area there, where you can get more information on the contact details for your trust, and a link to the most recent Encompass newsletter for some of the most recent news, and again, your trust contact details. For those that want to join us next month on the first Friday again, next month we're looking at secondary use of data. There's been quite a lot of progress going on, and in the session we'll have Francis Burns, who is the lead for protecting and promoting the interests of patients and public, and looking at the secondary use of data, informing decision making for people's health on that. So if you're interested in that, that would be good to join next month. And like I say, if you want to tell colleagues who have missed this session, the recording of this will be up on DHCNI TV at the end of next week on YouTube. And thanks very much,
Great.
everyone joining. Thank you,
Yeah,
Raied.
thank you for your interest, and have a good weekend.